Hello everyone. My name is Alex Floru, and I am an economics major in CAS. Today I'll be presenting my project analyzing legislation efficacy on mental health resource access nationwide and in Massachusetts. So before we begin, I would like to define mental health resources within the context of my project. I choose to define mental health resources as inpatient and outpatient treatment centers. These include both private and publicly funded psychiatric hospitals, general hospitals that offer mental health treatment, substance use centers, and residential treatment centers. Access to prescription medication is a necessary component in effectively treating many patients who suffer from mental health disorders. However, medication access has its own set of challenges, and I hope to address this in a follow-up project. So here I've combined some of the most common barriers to accessing mental health treatment in the United States from my research. Unfortunately, out-of-pocket costs such as copays remain high when accessing treatment, even for individuals with comprehensive insurance. Furthermore, insurance restrictions such as finding in-network providers often limit where people can access treatment. People may also face long wait times in accessing treatment due to provider shortages, and often must balance taking time off work to seek treatment. Travel costs, missed wages, and family obligations can also make seeking treatment a difficult choice. And here we see some data from 2018 to 2019. So 6.3% and 6.2% of people in Massachusetts and the United States, respectively, report unmet needs in their mental health treatment, and this percentage is believed to have increased during the COVID-19 pandemic. Out of those who report unmet need in mental health treatment, almost a third say it's due to costs in Massachusetts, compared with almost 40% nationwide. So for my project, I asked if legislation has any impact on accessing mental health resources or decreasing rates of reported illness. Here I've compiled 4 of the most influential acts I've come across during my research in relation to mental health disorder rates and access. The first piece of legislation that many of you are familiar with is the Affordable Care Act, also known as Obamacare. It was signed into law in 2010, and most of its major provisions came into effect after 2014. Among many things, the ACA reduced the cost of health insurance nationwide, expanded Medicaid participation, and abolished many factors that originally prevented people from obtaining health insurance, such as pre-existing health conditions. The Massachusetts Mental Health Parity Law of 2008 adds important conditions to pre-existing state law passed back in 2000. When it took effect, it forced insurance companies to cover the treatment of certain mental health disorders to the same extent that physical disorders are covered. This made it much easier for people in Massachusetts to seek mental health treatment without worrying that it would not be covered by their insurance plan. In the same year, a federal legislature passed the Mental Health Parity and Addiction Equity Act of 2008. It's somewhat similar to the Massachusetts Parity Law in that it prevents insurance companies from making mental health coverage, including substance use and associated disorders, more restrictive than coverage for other health conditions. And finally, one of the most important mental health acts passed federally in the last few years is the Helping Families and Mental Health Crisis Act of 2016. It notably tries to bridge the gap between physical and mental health care, allowing Medicaid to bill same-day mental and physical health care treatment. This is especially promising for those who must travel long distances to access treatment, or who struggle to find reliable transportation or can't afford to take multiple days off work. Furthermore, the Act allocates more funds towards preventative mental health care and preventative suicide measures on college campuses. All right, so here we can see 3 of the most commonly reported disorders individuals are diagnosed with while receiving treatment nationwide. From 2013 to 2019, depressive disorders have remained relatively constant from about 25% to 28%. However, trauma and stressor disorders have increased over 5% in the 7-year time frame, and anxiety disorders have increased over 8%. And here we can see payment types accepted by mental health treatment centers in the United States from 2010 to 2020. Again, one of the biggest barriers in accessing mental health treatment is finding providers or practices that are in-network to individuals. The amount of treatment centers that accept private insurance jumped from 10% from 2010 to 2015. And all other payment forms, including cash, Medicaid, Medicare, and state finance plans, increased during the 2010 to 2015 time period as well. However, since 2015, rates have plateaued and failed to increase much further, as you can see from the graph. And here we can see suicide rates per 100,000 individuals in Massachusetts versus the United States. I chose to include Connecticut and Rhode Island to compare rates in Massachusetts too, and from 2001 to 2017, all three states and the U.S. demonstrated an increase in suicide rates. All right, so following the data collected and analysis in conjunction with legislation passed, I've compiled a few key policy changes that should be addressed. First and foremost is for more legislation to reduce rates in suicide and common mental illnesses directly. So many acts passed both in state and federal legislature over the past 2 decades work to reduce costs for patients and increase access to treatment. And while this remains extremely important in combating mental illness, we saw that rates of stress and anxiety disorders along with suicide continued to increase during the 2010s, while depression rates remained relatively constant. Although most data is not readily available yet, many papers published in the past few years suggest rates of mental health disorders increase even further during the COVID-19 pandemic. States and the federal government need to work directly with doctors and providers of mental health treatment to better address the underlying causes of these disorders. Promoting community outreach does not seem to be enough, although the Helping Families and Mental Health Crisis Act of 2016 allocated funding for suicide prevention on college campuses. National rates in suicide continue to increase during this time frame. And although the ACA lowered Medicare costs and increased Medicaid access, only 28% of people in Massachusetts with a diagnosed mental illness are covered by Medicaid, compared to 21.6% nationwide in 2018 to 2019. Close to 90% of mental health treatment centers nationwide accept Medicaid, but as of 2020, only about 80% accept private insurance of any kind, not even including barriers such as insurance networks and high copays. Furthermore, 1 in 3 treatment centers do not accept Medicare. And while progress was made in the early 2010s in increasing payment types accepted by treatment centers, the percentages should ideally be close to 100%. No person should have to be concerned that a treatment center will not accept their payment type, especially in rural areas where treatment centers might be long distance away. So simply put, we need more legislation to increase the rates of Medicare and private insurance accepted at these centers. Okay, so for my last slide, following the completion of my project, I hope to next address access to prescription medication. So costs of medication and impacts of legislation are of particular interest when discussing drug access. Furthermore, many mental health illnesses such as schizophrenia may require long-life medication, and tracking rates of continued use could be significant in determining treatment efficacy. And finally, given that mental health data can have gaps and is difficult to find on a state level, I hope to gather anonymous data from individuals in Massachusetts. And I want to emphasize the ease of mental health treatment access by insurance type and socioeconomic status. Thank you.
Amazing presentation. Congratulations. I'm curious, in the slide where you were talking about the unmet need for mental illnesses, and you might not know this, do you know if they accounted for people who may or may not have a diagnosis or may be unwilling to self-report due to stigma?
Yeah, so those are definitely barriers when trying to find this data. Again, the stigma is actually a really important part. Thank you for bringing that up, because a lot of people, even if the data is anonymized, might not be willing to go forth with it. So I'm not sure 100% off the top of my head exactly what the details are behind the data, but yeah, that's definitely a restriction that needs to be accounted for.
I have a question about, can you go back to the graph where you're showing the Medicaid, the uses of funding?
Yes.
That one. Yes, thank you. So what surprised me by that, and please explain why I shouldn't be surprised by it, is the green line, that Medicaid is up there with like in the high 80s, almost 90% of costs. And so could you explain that in terms of then how you think about that and the implications of that, given legislative and other kinds of ways in which you might intervene in how insurance and legislative kind of, let's say, incentives work?
Yeah. So Medicaid has always been one that's been more accepted by a lot more practices as opposed to, as you mentioned, other forms of insurance. One common problem with Medicaid and Medicare is that a lot of treatment centers, not only for mental health, but also for like doctor's office, dentist's office, that they don't get compensated quite as much as private insurance. So even though they might accept it, they just might not bring on as many patients from Medicaid. They might say, oh, okay, like we're full, we have no room. And this stuff, of course, is not going to get reported. But that's another challenge, definitely. So even though it is close to 90%, it doesn't really mean that it's very easy for someone on Medicaid to actually get access at these centers.
Any final questions? I think we have time for one more, if anyone has one. If not, we will congratulate you. Thank you very much.